So I get the duty to talk a little bit about what's going on with the latest news in marijuana. I have a disclaimer: I've never inhaled, and unlike Bill Clinton, neither did I chew or swallow. Okay, so I have a bunch of disclaimers. I'm involved in a bunch of drug studies for epilepsy, for mitochondrial disease, and I forgot the Upshur-Smith midazolam study that I'm also involved in, so that's also something that I have to disclose. I'm an unpaid member of the steering committee for Dravet syndrome and clobazam, so that means that I spend all my time in the hospital gets my pay for that, which I think is unfair, but that's okay. Okay, so the big question: fact or fiction? So we have Charlotte's Web, which is the big name on the block for the use of cannabidiols for epilepsy. I didn't say marijuana. Cannabidiol is not THC. There's a big difference. So we have Charlotte. I don't have a picture of Charlotte Figge, but the book and the plant. Okay. So where are we in the treatment? You've just heard an absolutely wonderful talk about where we are in the treatment using meds. But just briefly, we have a bunch of new meds, and has there been any difference? And I think you could already answer that. But so if you look at this type of a graph, so this type of graph looks at efficacy versus tolerability. And the rubric of my field is no seizures, no side effects. So the ideal drug would be way up here. Look where we are. Now these are the new drugs. These are the drugs that have less side effects. We're still down here. And if you plotted the older drugs with the same sort of plot, you would be back here with a lot of side effects. So clearly, how we're doing our drug discovery is working for tolerability, but maybe not for total efficacy of seizure control. So just recapitulate. Recently, there's been a lot of new drugs. So the question is, since we haven't made any big hits, is this maybe because of all the great work we're doing in the NICU, are we selecting for more resistant type of epilepsy? And so our drugs are doing better, but we're not seeing the efficacy that we need to see. So it's interesting. So if you crunch the numbers, and about 2 a.m. this morning, I tried to crunch some numbers. So if you look before 1990 and before Starbucks, 37% of the population remain having intractable seizures. You know what? That hasn't changed. So let's just look at similar study that Gail Anderson just showed you and look to see if the drugs used before 1990 and the drugs used after 1990 shifted the first drug used and seizure freedom for a year. And there's a little bit, but not much. So we're only talking about a few percentage points. So we haven't selected for a resistant new seizure type. What we've done is we've created better drugs that act similarly on similar mechanisms that cause seizures. So there's a difference. So obviously we're not there yet. So are there other players acting by various different mechanisms that we really haven't thought about? So here is the proper name. So these are compounds found in botanicals, in particular one plant type. And so I don't know, I grew up in the era of burgeoning rock music era. And so this just came back to me when I was writing this talk. So you do have one pill that makes you taller and one pill that makes you small, but the one that all your parents give us just really don't do anything at all. So what do I mean by that is that I give you THC, I can get you high. If I get you CBD, cannabidiol, ain't nothing happening. You're bummed, right? So let's talk a little bit about the plant, because some of my patients have come in and telling me that they get leaves and stalks and they feel comfortable, so they isolate what they think is an active compound. But when you look at how you get the cannabidiols and the cannabinols, which is THC, they're found in this part of the plant, not down here. So if you're going to be a harvester, which it's interesting because some of the parents that I deal with are old people who grew their own, they'll tell you that this is where the action is, right here. Okay? And in the flowering part of the plant, that's where the glands are that make the resin that are the cannabidiols. So there are greater than 80 that they found. And the interesting thing is there are two major species. One is sort of isolated, which is the THC, because that's the only cannabinol that's in the cannabis plant. But there are a lot of CBDs. And the big problem is that in the older drug culture, they only cared about THC, so they started to breed plants genetically that give you higher THC than CBD. Now, there's also something called hemp. And for those of you who are really into this and been really trying to get it for your sons or daughters or yourself, there are places that will send you hemp from almost anywhere. But you have to remember that hemp has a higher concentration of THC, but a lot less concentration of CBD, and that's by law. And that was the FDA in the late 1800s that decided that they needed to curtail the hemp process from overseas. And so they enacted a law that's still on the books. I could give you that law, but it's really, it's government ease, so I don't want to spend my time. But so the two major compounds are the CBDs and the cannabinol THC, okay? So what's the difference? Is it just the name? No, it's the name, it's the structure, and it's also the bioactivity. So when you look, and what's sort of what we found is that there are specific receptors in the brain and in the peripheral system for the cannabidiols, which also bind THC. So in the brain, it's CB1 receptors, and everywhere else in the body is CB2 receptors. And they're involved in multiple different processes in the body. But we're sort of interested in maybe one and maybe more because there's a lot of interesting data that's coming out about some of these other effects that we can have with CBDs. So actually CBD was isolated or discovered way before THC. And the structure was known by 1963, and then the drug culture hit. And THC became isolated, structure was known. And this is when we found that there were receptors. And this is where we distinguish between receptors in the brain and receptors in the peripheral systems, mostly in the immune and in the blood producing system. And why would receptors be there? I mean, the body doesn't keep anything it doesn't need, except for fat, which I have living proof of. But otherwise, no. But what we found is that there are these endogenous cannabidiols, not cannabinols, cannabidiols. And they form two classes, they're fatty acids. And for those of you who take the ketogenic diet, it's really starting to change how we think about how we do the ketogenic diet, because fatty acids are what the ketogenic diet's made of, but that's a subject for another talk. So anyway, we discovered these endogenous ligands. But what's interesting is when you look at these fatty acids, they bind other types of receptors, not just CB1 or CB2. So we're just starting to investigate these receptors down here because likely they have actions in the central nervous system of which we're very clueless. If you go through the literature, you can Google these things and you get one page, where if you Google CB1 or CB2, you get dozens of pages. So we're not quite there yet. The question is whether or not these are primary or secondary receptors, and can adding the exogenous or the plant cannabidiols change these in any way? And the answer is, I think, yes, we do change these other receptors, but how, we're not quite sure. So what does this mean in epilepsy? So most of the stuff, interestingly, has come from animal models. And in animal models, both THC and CBD are anticonvulsant, meaning that they can stop seizures. Then what happens is, like anything, TV gets a hold of it, and you get the CNN report about Charlotte Figi and Charlotte's Web, and then everything becomes anecdotal, and we've lost sight that research really hasn't been done on these compounds. So what do we know in animal studies? They're pretty potent, and they really are effective stopping seizures. So if you look at just the animal models are pretty impressive on how CBD works. They work, okay? But there's a lot of baggage that goes on with this compound, mostly because of the name marijuana and where the FDA has placed CBD and THC in the same packaging together as a Schedule I research drug. So that means that I have difficulty getting pure compound to study unless I live in Mississippi, because they are allowed to grow it in Mississippi for study. But even in Mississippi, they're stunted on how much they can grow. And in the state of Washington, if your water bill triples and your light bill doubles, you will be investigated. Okay? Because you can grow it in your basement, but you can't grow too much. One of my parents, whose dad is a policeman, was investigated because that's what happened to him. And he said, yeah, I'm doing it, but I'm within the law. I just have bad plumbing. So what's the data in humans? So if you cursorily look at the data in humans, there are two really interesting studies. So there's this one study that looked at 215 patients who smoked, and of that, only 7% claimed that their seizures were better. Not scientific, but clearly not something that you would run out and buy your first reefer if you had epilepsy. Data just isn't good. And then this study looked at 63 patients in this total population of 310 that admitted to actually inhaling, unlike Bill Clinton. 53 reported no effect of the 63. So the majority who smoked, there was no benefit. So why the difference between humans and animals? So this is the reason, because the pill that mother gave you that made you small or made you tall got you high. The pill that didn't do anything at all stopped your seizures. So people were smoking concoctions that had high levels of THC and very low levels of CBD, because like any manufacturer, you go where the money is, and the money is getting people high. So you really don't care about high CBD in your plant. Now, just a sample, and I know this is one of the sponsors, I got this off their website, so please, I just took it off your website. So AC/DC, which is a very hot topic for the epilepsy group, because it has fairly high CBD in comparison to THC. If you look at the FDA, what they'll tell you is that they consider a product having no THC if it has less than 0.3% of THC in it. Now, here's Blue Dream Leaf, given an apropos name, because look at the level of THC compared to CBD. So if you were taking this for epilepsy, sorry, it's probably not going to work. Okay? So where are the good receptors found in our brains? And if you think about it, so the hippocampus, so those of you who came out of the drug culture or are in it, short-term memory loss and problems with smokers of marijuana is prevalent because there are a lot of CB1 receptors in the brain. The amygdala you get psychosis. So there have been studies suggesting that more psychotic people have taken or smoked marijuana when they were adolescents, and now they're adults, and now they're having problems. Frontal lobe, pre-motor planning, anybody who's been around somebody who is high on marijuana would not want them to drive them home. And the cerebellum for ataxia coordination, okay? These receptors are found in a different place in the body, so we're not worrying about them. The major player in possible seizure control is, this is where the money is. So if you're a bank robber, this is what you're gonna look at. They're found both on what we call excitatory neurons and inhibitory neurons. They're higher concentration in inhibitory neurons because when you think about it, it just makes sense. So if you have one of the new Teslas with a dual battery cars that go 0 to 60 in 3 seconds, you push down the accelerator, it takes a lot more energy to stop that baby when you get to 60 miles an hour if there's a truck in front of you. So you have to inhibit more than you accelerate. So you have to have more inhibition in a finely controlled system in order to handle the extra power. So the extra power is the excitatory part of the brain, but the stopping ability of your brain is all on the GABA receptor. GABA receptor is where we should be living, actually, but according to Jim Owens, but we won't go there. Okay, so seizures, well, so how does it seem to work? We're not quite sure, and so somewhere in here I put a disclaimer that I'm a learner, and I haven't learned all there is to how CB1 receptors work, so that disclaimer. This is just my view on things. So, does seizures change the CB1 receptor? In other words, why is it there? Why in animals do we see an effect, and why in humans, if you smoke marijuana, it doesn't work? So, is there a difference between having a seizure and an intractable epilepsy? And do we get upregulation of dysfunctional CB1 receptors in epilepsy, and because we can't control epilepsy anymore, that's why we can't control the excitatory neuron? Is that why we're having more seizures? Are these CB1 receptors are G-coupled proteins, so there's a pathway. And are we disrupting this pathway now? It doesn't work as well? Don't know. But I can tell you, and it doesn't show up very well here, but if you look at the epileptic brain and you stain it for CB1 receptors, this is a normal rat brain, and this is a rat brain that is seizing. CB1 receptors are about 100-fold increased. So, is it just the upregulation of CB1 receptors causing epilepsy? Or is the brain trying to put the brakes on these aberrant rogue neurons that are firing uncontrolled? So the data isn't, oh, and here's my disclaimer, because I'm trying to learn this as everybody else is. So what you have to remember is that we're adding stuff to the brain that the brain's never seen before. It's very similar to what the brain is normally used to seeing, but the receptors that nature has evolved with are not the same. So the binding characteristics of these receptors to this exogenous set of compounds is different. Okay? My play. What happens when we play with a normal system versus an abnormal system? Is there a difference? We don't know that, except for all the druggies that have come out of the 60s. So we've learned a little bit about it. The important point that we're finding out, the interesting thing is CB1 receptors are found on the presynaptic part of the synapse. So you would think that if you were going to control stuff, once you've sent a signal to your adjoining neuron to activate, you think you would want to stop it downstream from activating too much. But for some reason, the CB1 receptors are really upstream. So they're tightly regulating, we think, what's released from the neuron that's been excited or inhibited. So it's acting as a fine-tuned control. For those of us who dealt with Parkinson's in our residency because of domineering chairman, we found that the system involved in Parkinson's It's not so much you have too much or too little, is that the regulation, the tightly controlled regulation is missing because you have a neurotransmitter that's no longer there to tightly regulate how your basal ganglia, your cerebellum, and your forebrain are firing. Well, in epilepsy, is it the same? Are there subtle brakes on the system to keep the neuron from being overactive? And actually maybe on the other side of things, maybe activating certain neurons on certain conditions? We don't know that yet, but it's an interesting thought, and I'll give you some ideas how we think this may be working. So this is our favorite friends. We have THC, we have CBD, and these are the basic groups of endogenous cannabidiols. Now, if you notice, here's where the money is. Here and here, you can see that the compounds are changed. There's a different conformation. Cannabidiols bind CB1 receptors with a 10-fold lower Km value, which means that it sees it, it really likes it. So it's like a male that sees a Ferrari. We're drawn to the red Ferrari. But the Km is lower. It's a Pinto. we can get into that because it gets us from here to there, but it's not the Ferrari. So that's like the difference between binding sites. And then there are these compounds, okay? So CBD binds the CB1 receptor less well than the THC. Why do we think that's important? Let me sort of get there. So in the brain, we have a nice balance between what's excitatory and what's inhibitory. We need a balance. If this is out of balance for some reason, trauma, genetic mutation, if you have Dravet's, if you have an infection and meningitis, you can upset this balance and you create a differential in tone. So if you have more excitatory tone in your brain than inhibitory tone, that means that your excitatory neurons can be stimulated and less well controlled. So if epilepsy is uncontrolled firing of neurons, then it makes sense that if you accentuate the excitatory tone, you're going to be more prone to have seizures. And that's sort of the way I learned epilepsy. Now, why do we think this is likely in CBD? We think that CBD is actually balancing out this tone between being too easily excited with a Ferrari and the real life in the Taurus. Okay, everything becomes balanced. And the whole, our whole system is trying to keep this balance. Okay, so this is a neuron, two neurons. You get, let's say this is an excitatory neuron. It's trying to teach you how to remember to spell cat. So you fire this enough, you create synaptic density way down here in wherever it's ending up in the temporal lobe. And because it's fired a lot, it's become more hardwired, and now you're thinking, okay, cat, C-A-T, okay? And it's all the result of a lot of chemical reactions, and one of these is right here, it's a synapse. You get release of the neurotransmitter, it activates this neuron, you get a firing of that neuron, okay? Now, so if you look at the GABA receptor, and I just take that first because Dr. Owens thinks that this is what runs the world, how we think, or how I visualize the CB1 receptor working, is that you get transmission from a GABA neuron, and we're going to inhibit this neuron. So it releases GABA, which is a neurotransmitter, which will bind to its receptor, which turns down this neuron. Now, after a release of so many of these little vesicles, you stimulate the CB1 receptor because of the endogenous cannabidiols, which are fatty acids and found in the membrane of the presynaptic region. It now binds CB1 receptors. It turns on a G-coupled protein, and the signaling pathway, I'm sorry I'm echoing, starts to turn down this process, starts to control it, okay? On the other hand, The excitatory neuron, the glutamate neuron, same thing happens. So you get a firing, you get release of neurotransmitter, you get activation of the next neuron. And when these vesicles merge with a presynaptic vesicle, it binds the CB1 receptor, hits a G protein, and this process slows down. So if you had a car and you didn't have anti-lock brakes, you slam on the brakes, your wheels lock up, and you slide forward. Think of CB1 receptors as the anti-lock component of your better brakes. So you slam on the brakes, your CB1 receptor kicks in, and now you have a sensing system that backs off the brake when needed so your wheels don't slide. And you stop almost seamlessly because the sensing system can back on and off because you're subtly regulating release of these neurotransmitters that's stimulating your forward progress or the excitatory neuron. What happens if you have epilepsy? So now you're driving and you're going downhill on a wet road. You slam on the brake. Unfortunately, the wet road and having the imbalance between excitatory and inhibitory systems, and even though you're backing off on your brake as best as possible, you're sliding down the hill because of the wet road because your brain has been altered, and you crash into the car in front of you. That's epilepsy. The right mechanisms in controlling how information is changed within your brain has been altered, and that alteration changes this interaction as well as the GABA ability to stop the on-moving car or the excitatory signal. So what do we think that CBD is doing is we think that it's now, because you have way more receptors, remember? With the brain that's seizing, you have way more CB1 receptors. So we're adding CB1 receptor agonists or cannabidiols, and it's starting to do this and help out the system. Well, we don't have any drugs for this. CBD is working on a novel mechanism, we think. And then the problem with excitatory neurons, as somebody pointed out about calcium, is you get this little guy here that can accentuate your problem that you're not really controlling well. So there are more problems with excitatory neurons than inhibitory neurons, but nonetheless, this is the way I read the literature, is this is how cannabidiols are working. So how is it working? This is the black box. So are we futzing with how the GABA receptor and calcium channels in the excitatory neurons are functioning? Or are we playing with the CB1 actual receptor G protein pathway? And I don't think anybody knows that yet. I would vote for the latter because as of yet, there are no CB1 receptor mutations that we know of. But you know what? They gotta be there. Everything in our body tends to mutate after a while. They gotta be there. We just need to find them. And that could be a reason why we see such heterogeneity in the Dravet population. Because in the Dravet population, which is really the right population to start to study this stuff in, is they have a GABA problem. And we know that by the drugs that work in Dravet. They're all GABAergic or enhanced GABA in the brain. The other stuff that works on blocking excitatory stuff can actually make things worse because the whole brain is already out of balance. So my vision of how the CB1 receptor acts is a rheostat mechanism. It allows the brain to fine-tune excitation and inhibition. So you remain having an equal distribution between excitatory and inhibitory tone in the brain. So to summarize, we think that epilepsy is this imbalance between excitatory and inhibitory, which is much too simple, but I'm very simple. So we'll start with there. Frequent seizures accentuates an imbalance. If you have a genetic mutation, it's even worse. If you have trauma, it's even worse. If you have brain infection, it's even worse. And the dampening mechanisms can be intrinsic because of genetic fault, or extrinsic because of an infection or trauma. So, can this system actually control seizures? So, it didn't work out right. Okay, so this is data that's 3 weeks old. There was an R&D meeting at GW Pharmaceuticals, and they presented data 16 weeks out from their IND study, looking at CBD and epilepsy, mostly in the Dravet population, but also Lennox-Gastaut. So there were children and young adults. The average age was 11 years. The average number of seizure medications before starting the trial was 3. So the definition of intractable epilepsy is the failure of 2 or more drugs. These kids were on an average of 3. They are already intractable. 58 patients were enrolled. So just look at this data. The dark blue is seizure freedom. And if you look, it's pretty good. But as impressive is the decrease in seizure frequency in these patients. So if you had a novel drug and you told the FDA that you had 40% reduction in seizure frequency in a trial, the FDA would approve your drug, because that is really good. Now, you also have to see this with the other side of the fence, is that we still didn't control everybody. So obviously there are more mechanisms of how this imbalance occurs that we have to look for, but when we're looking for different mechanisms to control for epilepsy, it looks like this may be a winner, and we need to investigate this more. So let's just look at the Dravet population. The N was 12. But when you start looking at this, almost a 60% seizure reduction in this population. That's really outstanding. And you have to deal with Dravet's patients. So I have a cohort of about 32. Marcio Satero at Swedish has a cohort of about the same, maybe a couple more. And we always email each other, because we're always asking, is there something else? Because little Billy or little Jane is having a bazillion seizures. I've got them on the right meds, and they are still seizing daily, or a couple times a month. I can't control their seizures. This is in a population where I can tell you that I know some of the patients, and they were on the right meds. They were getting what clinical trials have shown: clobazam, valproic acid, stiripentol. That works in this syndrome. And yet, we see this added benefit. So, in this population, using this type of mechanism of presynaptic control, CBD seems to work well. It's only 12. So this company wants to increase that to get FDA approval for this syndrome. Now, what about drop seizures? You know, if you treat kids who have Lennox-Gastaut, the drop seizures are the worst. That's what cracks open your eyebrow and you need stitches. It gives you chin problems. You whack your nose, you break your nose. You fall, you hurt yourself. You become an embarrassment almost to yourself. Psychologically, you're just wrecked because you're waiting for the next event to happen. So in this population, which is what we see in the Lennox-Gastaut population, if you can control those, that's wonderful. Well, just look at the drop seizure rate of control. We're talking around a little bit over 50% betterment in drop seizure control using CBD. That's a pretty tremendous number. So what we don't know, and these were short studies, these were 16 weeks. We don't know the long-term efficacy. Is this going to be a waxing and waning deal? We don't know. Is it just Dravet population and Lennox-Gastaut population? We don't know. There are anecdotes, and because I work with a genetic company that we're trying to learn the calcium interface with Dravet's, as well as how drugs are metabolized in a particular patient. I am privy, luckily, to other certain things that are just beginning to come out. There's a genetic disorder called CDKL5, which is a terrible epileptic encephalopathy. It's pretty rare. But there are 2 cases that will be published shortly that CBD has worked for. There's a terrible gene duplication on 15q21 through 23, and nothing really works. There are 2 kids that have been treated with CBD that seem to have a benefit. Numbers are way too small to speculate, but at least it gives you the idea that there's some common ground here that this drug may work, and we need to explore it more. So botanicals change your basement into growing facilities. No, I'm only kidding. So the unanswered questions are how CBD and the exogenously induced binders of CB1 receptors, how they really work. Can we enhance the endogenous system to enhance seizure control in epilepsies that are a little bit easier to control, where the balance isn't so dramatically skewed? What are the conditions? We're clueless. What are the conditions that seem to respond to CBD? We really don't know. That needs to be ferreted out. How do we dose this? And what are the long-term side effects? Especially since we know that long-term THC dosing can have adverse effects. Is it the same for CBD? Most likely not, because in animal studies they don't show that, but we don't know. And certainly the FDA is concerned about that, and that's why they scheduled them together, THC and CBD, as Schedule I research drugs. And are there good clinical syndromes and or genetic syndromes that may respond better to CBD? We don't know that yet either. This process has only begun, and the unfortunate thing is when processes like this begin, you as a patient with epilepsy and your children who have epilepsy are the petri dishes, and that's the unfortunate thing. Because at this point, animal models work, but they haven't told us everything. So, thank you, and questions.
I'm going to try to say this as fast as I can. So our son is now 26. When he was 16, he had a protein S deficiency, stroke, massive seizures, brain surgery to stop seizures on the frontal lobe. He's on 4 seizure medicines now, not working. He was having anxiety attacks and all that. He has been doing the pot on and off. I have no idea what kind. It's just whatever, wherever he gets it, I don't know. Will that help? And because he's having it for a long time, is that bad?
At least when you look at the studies that looked at people who smoked, most of them said it wasn't helpful.
But it just calms them down enough so they can...
Likely not.
No. Okay, all right.
But we don't know. I mean, that's why we need to do research.
Yeah.
But at least with adults who were smokers, not many of them said that it really helped them for their seizures.
No. Yeah.
So
He's still on. Okay.
I have to go with a microphone, so
So if you're smoking weed that is high in CBDs,
I don't know if you can find it.
Yeah, you can. Yeah, at the medical marijuana, it's high CBDs, really low on THC.
So how much? Where's your lab? And who tested it? And what's the milligrams of CBD to percentage of THC?
Oh no, it's specific. It's like 4 or 5-fold.
Yeah. When I get
higher.
pizza, I order the pepperoni with a lot of pepperoni, and it varies.
Yeah.
Because it's not regulated.
The CBDs in this particular case are like 4 or 5-fold higher than the THC.
It's not very much.
Okay. Well, anyway, so majority CBD. Does the fact that you smoke sativa or indica affect, sativa's more excitatory, indica's less so?
We don't know.
Hybrid. They're hybrid. AC/DC and remedy are hybrid.
Right. But does THC affect the ability for the CBD to bind in animal studies?
In animal studies, cannabidiols act as a non-specific antagonist to THC's effects on CB1 receptors.
So, in layman's terms, they would reduce the high, that the CBDs would counteract the high of the sativa or indica.
Well, it would depend on your receptor distribution, but it could.
Okay. In animals? I guess you can't tell, huh?
No.
They don't get all excited?
No, they do. I mean, that's the interesting thing. You can tell a mouse that's high on anything. You know? I mean, they wear their hearts on their sleeves. Or fur.
So, in full disclosure, we actually have a daughter who's 15 months who we've had on CBD for 2 months now. And again, anecdotal evidence, we have seen a vast improvement both in seizure control and just her alertness, overall alertness and development is coming along. She has some SCN mutations, and I think you're going to say we don't know, but I'm curious about efficacy versus GABA versus potassium channel versus sodium channel de novo mutations. Has there been any study on that?
Well, the Dervais study, I mean, they are bona fide SCN1A mutations. So if you have an SCN1A mutation, there's a good chance that that may be the mechanism that the CBD is working through the GABA neuron in that situation.
She's a 2 and a 9.
So a 9's a modulator. A 2 can give you encephalopathy, which we're just learning about. 9 can also give you a pain syndrome. So it's really hard to tell, because we're finding that there's a lot more interaction between the sodium channels than we once thought. So it's not a simple one gene, one disease, because Dravet's phenotype, or the way it looks, is all over the map. There's some kids that are easily controlled and some kids that are way more difficult to control. There are some kids who really respond to clobazam and some who don't. Some who really respond to stiripentol and some who don't. And so we're just learning how complex genetics may produce different phenotypes.
Are you looking at different plant phenotypes and strains, as well as ratios of CBD to THC?
Well, the geneticist at Kevin, yeah, he sequences a lot of the different plants, so we know the genomics of different plants that are used. What we're really trying to ask the question is, what other drugs are you using that may modify the CBD concentration? And what are the other genes that may be modulating how different receptors respond to drugs, i.e. the calcium channels? So in a small grant that we proposed to the Dravet Foundation, is we're going to sequence every kid's cytochrome P450 and calcium channel gene to see if there are polymorphisms, and can we tease out why some respond so well and some don't. So that's something that we're very interested in. We're doing it with Gail. We're doing it with the people in Colorado, but we have to get funded.
In the back.
Hi, I know you're getting hit with a lot of questions. So I'm a respiratory therapist. I've been one for 26 years, and I got blessed with seizures about 7 years ago, had my brain surgery 5 years ago, left temporal, and I've just kind of been handed all these questions about all this. One of the things that I warn people about is if you're smoking it, it is a bronchodilator, and I'm waiting to see lung cancer explode down the road. Also, when it first got legalized, I was told that people could use 200 herbicides and pesticides to grow pot. And so at the conference we had with Dr. Vosler at the Epilepsy Foundation, it was brought up by parents. Are you also asking them, do you check for mold, mildew, fungus when it's being grown? And so one of the things that I got my prescription for CBD from my naturopath, because the neurologist cannot legally give it since it's not legal federally.
Yeah.
So I grabbed it and I talked to one of the guys, he owns the Seattle's Best Cannabis, and I quizzed him up the wall. And I just said, you know, do you test for this? And he says, yeah, I only do it for medicinal reasons. There's a guy up in Sequim that he's a biologist and a chemist. And if you get on the website Analytical 360, it will break down the exact amount of THC and CBD and who is selling what. So I kept holding on to it going, I know I'm not meant to take it. I ended up, I had a friend who got diagnosed with cancer, was using the THC for appetite and of course for
And pain.
pain.
Yeah.
So since he had the prescription, I went ahead and gave him the CBT tincture. And I went, well, why am I still have this question? So one of the things that I would like to know is that since it's illegal, let's say that one day I decide to do it, legally, let's say I got laid off in healthcare or something happened, even if it's a 0.75, does that mean I cannot apply for a job? Is that something that they're looking at? And I had a police officer yesterday who has to apply for a CDL also, and said that legally they're told they can have no THC, none. And I don't know if you've heard anything at all? So there's like all these questions going on, of course, with the marijuana.
Well, I can tell you that THC stays around a long time because it's very lipophilic. So it gets in your fat. It takes a full 30 days before it really washes out. But as far as I know, the urine tox screens do not pick up CBD. They do pick up THC, and they don't pick up spike or the designer marijuana-like substances. Now, those really bind probably CB1 receptors avidly, and we know they cause psychosis. So, you know, there's this balance of how much CB1 receptor you want to excite and how much you don't, and in what kind of scenario that you're doing that in. And it's going to vary. And unfortunately, it's pretty much going to be personalized medicine because you're completely different than little Billy down the street who has Dravet syndrome, who's different than little Sally who has PHCD19, and Johnny who has CDKL5. And so, you know, you have to do it per patient, and it takes a while to figure all that stuff out. And it really takes a long time when we don't know a lot of stuff, and that's the major thing. So we're starting to learn. It's starting to come around, but it's always too slow if it's your child or if it's you.
Hi. I have a 9-year-old kid with epilepsy. We're starting we're going to start CBD treatment. We're based in Vancouver, so at a federal level, medicinal cannabis is legal. Now, we're going to get a strain from Bedrockin called Bedrock Light. Has 9% CBD and it's less than 1% THC. My question is, because our situation there, we can legally buy it and register for it, but we only are allowed to buy the dry plant matter. And my question is regarding oil extraction, and because we're left alone to do it ourselves. And my question is regarding decarboxylation. Are there any studies done showing like an advantage on or not in CBD in acid form or decarboxylated? Because we're trying to do it edible because it's 49 years old.
Good question. At least the tinctures are, because it's so highly lipophilic, that extraction in an oil is probably better. It is an alcohol, so you could dissolve it in an alcohol base, but then you would have to get rid of all the alcohol because obviously you don't want to use alcohol because that's toxic as well. So, having never grown it myself, I've only talked to people who isolate it, and they say it's no problem to get it out of leaves and stalks. I mean, that's sort of hemp. And the whole idea of a lot of places going to clinical trials with their product is the difference between using hemp and the difference between using a GNC labeled product, which has to be validated and go through a lot of testing before it's actually used. That's a similar problem that you're talking about. So you have a plant that's in dry form and you need it to get it to some place where you can deliver it properly. I don't think I would isolate it in acid just because of the structure of CBD. But then again, you know, I did well in chemistry, but this was not the type of chemistry that I did well in. So I'm not sure I can help you, but there are people out there that can really help you because they do it routinely. So, not me, unfortunately.